Okay, so we are going to start with the slides. And with this, I'm going to share my screen. So you can see my screen, right?
Yes.
Okay, so this breakout session is about remote patient monitoring. And in our BigMedilytics project, we have 3 different pilots who are using remote patient monitoring. And this is the pilot 2 kidney disease, pilot 3 diabetes, and pilot 4 COPD. And basically the idea for the discussion is to bring this kind of more to attention. Is anything unclear from the short discussions in the pilots? What is our experience with remote patient monitoring, and what are our concerns? So I'm going to start with kidney disease, and kidney disease is a major population burden for the population. 10% of the global population have some kind of kidney disease. Fortunately, only very few patients have chronic kidney failure, but this is a very costly procedure to be on dialysis, and we all know that the quality of life is really reduced, and you are just merely allowed to survive. And the treatment of choice is kidney transplantation because it has a lower mortality, a better quality of life, and lower cost. And this combination, I think, makes it unique that someone has a better quality of life, lower mortality, and it costs less. Normally in chemotherapy, you have to pay for every quality of life years gained. So kidney transplantation is a treatment of choice, but it is a complex lifelong treatment. Many patients need frequent hospitalizations, they have complications, and premature graft loss occur due to complications or non-adherence. So our vision was very simple: to connect the patient who is in chronic treatment with their treating physicians, and this is a transplant center, and this is a home nephrologist. And the idea is that in order to bring this together, that with remote patient monitoring, we are able to detect complications early and reduce hospitalizations. And this is how it works. So basically the patient at home,
Okay, so as Klemens has some connection issues, we will go to the next pilot. This is pilot 3, which targets the gestational diabetes, which is a disorder which develops in women during pregnancy because the mother is not being able to produce enough insulin. GDM also represents a major public health concern, as the affected mothers have a high probability to develop type 2 diabetes at a later stage in life. And globally, the numbers of patients diagnosed with GDM has dramatically increased over the last 2 decades due to inconsistencies in the screening approaches, poor glycemic control, and also the international adopted changes in diagnostic criteria. This, together with a more sedentary lifestyle and increased obesity and the advanced maternal age. So such rapid changes in this prevalence, together with the COVID-19 pandemic, have resulted in enormous pressure on the healthcare system, and it was required an urgent change in current practice. So at the initial of the pilot, we conducted an extensive state-of-the-art analysis, which provided us with relevant insights about the use of RPM and remote patient monitoring technologies and the economic and also health benefits. As you know, this process was overly manual, prone to human error, time-consuming, and requires a lot of resources from the hospital. As for example, midwives receive approximately around 100 calls per week from patients to detect their blood sugar levels. So the partners of this pilot, Nisatec, Huawei, together with Rotunda Hospital, have been working together to develop an AI solution for GDM care, which facilitates self-management and remote monitoring of GDM through the use of a mobile app, which is linked to a secure medical portal. So next slide, please. So how does it work? All the patients that were recruited in the study were provided with strips and a glucometer, which is equipped with Bluetooth. So the process is very easy, as the patient can easily connect and pair with the mobile application, which is available in both operating systems, in Android and also in iOS. So the patients are able to record their daily blood sugar levels from home or from anywhere else, and providing 4 measurements a day as required by the clinicians, 1 fasting and 3 post-meal. And the application also has additional features, so the patient can input their food intake and also the daily exercise, which is also of relevance for the GDM treatment. All this information is collected in real time, so the clinicians are able to access and monitor the information gathered from the app remotely and can help the patient in managing their conditions without having to visit the hospital on a regular basis. In addition, the application has also some education material, such as videos, tips, and frequent answer questions, so the patients can learn about the GDM disease. And here on the right-hand side, you can see some screenshots of the application and how it looks like. Next slide, please. So how people can use the technology as a whole. So the patients can easily from home or anywhere else keep track of all the blood glucose results, fasting and also post-meal. They can also monitor the impact on the food and also the activity and daily exercise. They can also track their weight, and they can also request feedback from the clinician in case they don't feel well or they have some issues with the measurements. And also, as discussed, they can check at any time additional information about GDM. So all this information is collected in real time, and this is sent automatically to a portal, which is deployed at the hospital server. So all raw data is stored within the IT infrastructure of the hospital in a secure environment within their firewall. And in addition to the information collected from the app, the clinicians can also visualize the results of the AI models that we have been developing in the pilot. One model is a diagnostic model, which assigns a risk score to each patient according to the blood sugar level measurements. And we evolved in the last stage of the pilot and combine other relevant parameters such as age, BMI, tolerance to glucose to develop a more predictive approach. So this model now takes into account all these measures in addition to their sugar levels, and can calculate the risk of a patient to have values above the established thresholds within 7 days. So all this information can be easily visualized in this medical portal. So the clinician using this portal can also register and create patients' login details. This is the first time. And then once the patient is set up in this web, the patient will be asked to provide a new password in order to comply with the data protection regulation. So the clinician can easily visualize all these results, and also there is an alert system which identifies which patients are above the established thresholds and requires immediate attention. So the clinician can also send notifications to patients via the mobile for a checkup, And additionally, they can also send positive feedback when the patients are doing great and complying with all the proposed treatment and activity plan. So next slide, please. Some of the lessons learned and difficulties that we have encountered in this pilot were basically related to the quality of data, which heavily relies on patient compliance. So we found that many of the patients were introducing all data about the measurements, and also they did not indicate whether this measure was pre or post, which makes it very difficult to develop the models. So this is very important that the patient complies with all the indications. Also, we found a lot of challenges in historical data in order to interpret correctly the data, cleaning the data, and so on, because we use the data from Rotunda Hospital, and also we were using some data from another hospital in Ireland in order to have large data sets. But we found a lot of differences in the features, in the information that was collected, and many different types of unstructured test data. And also in the last stage, as mentioned, we were aggregating other parameters in order to make the model more global and that can be easily applied to any other country, as for example, ethnicity. However, this can create some bias in the results. It means, for example, if one patient with given ethnicity has no risk values, the model will learn that all patients of this given ethnicity have no risk at all, which is not the case. In terms of take-up of the technology, we found very interesting to collect demographic information, as was extremely useful to evaluate compliance with the mobile app, and also e-health literacy. And regarding the willingness of the clinicians to adopt this technology, in our pilot, all Rotunda clinicians were very positive about it, but we also conducted a national survey of all of obstetric diabetes units in Ireland, and the results were extremely positive, and all of them were in favor of adopting this type of technology as they consider it practical, safe, and feasible. And regarding the willingness of the patients to use this app, we found any concern about data privacy. We didn't find any problem about this. Everyone was happy to use this application, as they were informed about the scope of the study, the objectives, the rights and obligations to participate, and also all the security measures in place and all the GDPR requirements. And actually, no one has withdrawn from the study for this data privacy concern, no concerns at all. So this is basically a brief summary of this pilot.
Thank you. You can hear me, can you?
Yes.
Oh, I was just concerned that I hadn't put my microphone on. Right, so the third pilot in this section, and we may go back to Klemens in a bit, is the COPD, so the chronic obstructive pulmonary disease pilot, which was based around an existing app, and our experiences in integrating big data technology into the back end of that app. COPD itself was reported in 2019 by the World Health Organization as being the third leading cause of death, with a little over 3 million, so about 3.25 million deaths for that year. COPD itself is a whole range, a series of different conditions, but they all share the features that there is a persistent and progressive loss of respiratory function. And in the past, people have assumed that issues around the environment, the context in which the patient grew up, developed, were important. We know that things like pollution, we know that things like tobacco smoking are significant risk factors. But taking all of that together, the idea in the project was to be able to track symptoms, to be able to predict an exacerbation. An exacerbation is simply a very sudden flare-up of symptoms. And so typically the COPD sufferer might go to hospital to get checked out and to be stabilized. The app itself, and I described this in more detail yesterday, and also on the booth there is more information, and provides a lot of educational information like the GDMapp, but it also provides two very simple streams of information. One is the CAT score, the COPD assessment test, which is an independent instrument developed and validated for some years now within the respiratory community. And as you'll see, there are 8 simple questions asking people to rate how they feel on a particular day. That produces a cumulative score which correlates to the physical state of the patient. The app, however, also includes a subjective measure, namely the symptom score. As you'll see on the right-hand side, it's very simple. 1 of 4 options. Do I feel as I do normally? Is there some deterioration? Is there actually more? And in fact, am I really struggling? So 4 options, and those 2 data streams are collected for the machine learning, and then we attempt to model and predict any exacerbation event. And so on the basis of that, recognizing that these are 2 very simple measures, one is objective, one is subjective, and the assumption is that those will correlate with each other. But importantly, they're just very simple measures that actually allow us quite significant prediction capability. So the AUC is something like 80-85%. The intention is that alerts from the prediction model will go into a decision support system, and the clinician can use that for a whole bunch of different reasons. They might actually contact the patient and say, have you been keeping up with your exercises? Have you been doing this, that, and the other? But they may also decide to contact the patient and advise them to go to hospital, or even just take the initiative and send an ambulance. On the left-hand side here, these are the possible things that we could do. Of course, there is quite strict regulatory control on the automatic alerts that can be sent to a patient, because there needs to have been an auditing around the accuracy, etc. You don't wish to distress the patient, and of course, during the pandemic itself, you definitely don't want to distress the patients who need, as a vulnerable group, need to isolate and protect themselves. But nevertheless, it's possible to provide an automatic alert which says, you're not doing the right thing at the moment. Have you thought about doing this? Have you thought about doing that? Maybe it's time to contact your specialist nurse or other clinician. And even, and these are the more tricky and sensitive ones, tell somebody to get themselves to hospital immediately. The difference in the UK between calling 111 and 999, 111 is NHS Online, so they will provide a triage based on a script. So it's a lower level of emergency. 999 are the real emergencies, and typically you would ask for an ambulance. So those are all the potential things that come out of this application. And of course, as I've stressed, there are 2 very simple data streams which are allowing this degree of prediction accuracy. And so, of course, if we look, and I said at the beginning that COPD is very sensitive to environmental factors. That's not just the development of the disease in the first place, but ongoing, so things like weather or pollution. And of course, there is a lot of this data available. It's published on government websites, on the Met Office, etc. will provide this information. But part of the problem is to synchronize the data, because typically patients will be reporting either completely regularly, so on a daily basis, or less regularly. But the weather and pollution measures tend to be at specific intervals, so you've got to try and mesh the two together. You will not get, certainly through publicly available data sources, enough information that corresponds directly with what the patient is saying. We also need to be able to identify, and we can't do that at the moment, at a more granular level, where those bits of information actually relate to specific individuals. Because, for example, a pollution reading 3 miles away is not relevant to a particular patient. But of course, that introduces issues of potential re-identification. If you know the location of the patient, then yes, that would increase the accuracy. But on the other hand, it would also identify them. And so there will have to be additional measures in place. We looked at and I reported some of the figures yesterday. We looked at the retention and adoption of the app. And we asked various questions. We also did a nationwide survey, but to ask members of the general public about their feeling about using healthcare apps. Digital literacy may be a problem. People are not comfortable using apps for whatever reason, but we didn't find that in our sample, and it was balanced across the demographics of the UK population. As far as a willingness to use apps, it is reported in the literature that some patients particularly don't want to use an app because they feel that they're being pushed aside. Resources tight, so you're not that important. We didn't find this, as Marga reported for GDM. On the contrary, people seem to think that it was actually quite useful. The other issue reported in the literature is that if you disrupt in any way the clinician-patient relationship, the trust relationship, this may not go down too well. We haven't found that at the moment, although an independent survey looking at myCOPD itself found that the clinicians were far less happy to engage with the app than patients themselves. And then finally, the sort of general things about technology, about privacy, etc. Again, and this was found in the GDM study too, there were fewer concerns about privacy. People thought, as long as it's helping me, and as long as the data are helping the community, then we're comfortable with that. So that's COPD. So that's the third application. Okay. I think in that case, if there are any questions that people have, please come back to us either on either through the booth or through the general chat, and we will happily answer that. But we'd also be interested in any of your experiences around using remote monitoring with patients. Is there anything that you wanted to add, Marga? Because I was interested.
I think it's pretty much the same architecture.
Yeah, we have similar architecture, and I was looking, on this particular slide, and as I sort of hinted, certainly in the UK actually providing automatic prompts back to a patient is very, very strictly regulated. So I don't know what the rules are in Ireland or in Spain, but are you able to do that?
Well, yes, true. In this case, it was applicable the national regulation in Ireland.
Right.
So we have to go through all the ethics committee to explain in detail the study and the objectives, the applications, and we found that initially all the functionalities of the app were classified as a medical device, because there was initially a function in the app which was a traffic alert system. So that was considered a risk of patient for the patient, as they say that was sending notifications, not as a clinical device, basically. So in order to overcome this challenge, we modify, revisit the requirements. We found another solution for that. So we replaced this alarm system. So instead, only the clinicians are capable of receiving this sort of alert. It's not an alert, but it's an identification of patients which are out of the safe thresholds.
Yeah, that's pretty much the same issue in the UK. And moving forward with the pilot into the next phase, the plan really is to investigate the what level of alert is appropriate, sit down with patient groups and discuss with them whether they think it would be a good idea, what the risks might be, what the options should be, and then on the basis of both clinician feedback and patient feedback, try to make the decision whether it's worth going through the bureaucracy for the medical device. And I don't mean that in a sort of detrimental sense, but you know what I mean. It takes a long time.
Yeah, exactly. In any case, we prepare all the documentation. We conducted a risk assessment, a DPIA, a lot of validation tests about each functionality, and all was presented to the HPRA, the national regulatory body. And we were continuously in communication with them in order to provide them with all the updates. So in the end, it was considered not as a medical device, but as a supporting mechanism to the standard GDM care.
Yeah.
And actually works very well, and it was well received also from both the patients and also the clinicians.
Yeah.
The way that is working right now. Yeah.
And so that still doesn't include the alerts going to the patients?
No. They only receive a notification from the clinicians when they found that there is a risk for the patient.
Yeah.
That's all. But they don't access the results of the analysis or any of these AI models, only the clinicians.
No, that's really interesting, and I'll bear that in mind as we go forward as well in the UK. The other thing, which is kind of related, though it's not regulatory control, but one of the issues that you always face with clinical trials, etc., is the level of ethics governance.
Yeah,
is stricter when it revolves around patients. And what we've done in some cases, and this was not, deliberately to avoid the appropriate approval, but to look at the app, because it wasn't providing any automatic alerts, it was just collecting information in a similar way to what the HPRA had said in Spain, that it's actually an application, a device in support of something else. And so therefore we don't need the ethical oversight for patients, but rather the ethical oversight for app users.
Yeah.
And of course, one of the difficulties, in most countries anyway, is that whether somebody's an app user or not, they're bound to be a patient of the health service in that country. So those were some of the issues that we came across.
Yeah, so pretty much the same difficulties as well.
The other thing that I was interested in, going back to this slide, so the incoming data, as I understand it from this, is the blood sugar level.
Yeah, this is the primary source of data.
Right.
However, it is also of extremely relevance for the clinicians to know whether the patient is following the indications about the diet and also the exercise. So the app is, the patient can introduce information about any type of meal, and the application is connected to a global public database which provides the calories of this type of meal. And also it's so relevant because depending on the measurements of the glucose, depends, the clinician can know whether the patient has been eating, I don't know, a cake or any other not recommended food. So they can establish the pattern why this is happening. Also, they provide some recommendations about the daily exercise to walk a certain number of walks during the day, and this is also collected via the application. The mobile app has also a pedometer, so for the patient it's very easy to calculate how many steps. And also they can provide manually input about any other exercise if they go for swimming or any other type of exercise.
Yeah. That's actually really interesting, because we, in our case, so the myCOPD app actually provides educational materials, to tell people about COPD, and then there are things like training videos for how to use an inhaler, what exercise you should be doing. But we don't have access at the moment to those, to any indication of how much engagement there is.
Okay.
So we don't know that. The clinicians will know, but we don't know that. That's not part of our modeling. But what I'm understanding here from the GDM app is that you have different possibilities to pick up different types of data, but also there is a mix of self-reports, so the manual input, and the more sort of automatic, like the using the glucose reading. The patient couldn't tamper with that.
Yes, because in the previous, in the standard process, the way that the clinicians were collecting the data was overly manual. The patient has to call the hospital, so the midwives have to stop their daily task, and they have to answer like hundreds of calls a week. The patients had to dictate the glucose levels, and in many cases it was found that they were providing wrong data. We don't know if that was intentionally or that was a mistake in readings or what it was. So this way, as the glucometer is directly connected to the app, there is no probability of error in transcribing this data. So this is a huge advantage as well.
I can see that, because of course the other pilots as well, whether they're using monitoring apps or not, have reported that there is this issue that patients may get things wrong. You don't want to say that they lie particularly, but they might underestimate or they don't want to say that they've eaten 4 donuts. And so there is that problem. But having these different streams, so some of them are objective and there's no way that the patient can interfere with them, and others are manual. You could actually check the manual ones. Is this consistent with what we think? Interesting. And then finally, I'm assuming poor Klemens is not able to.
I think Klemens is not online.
Okay. We have the same problems, and I think most of the other pilots we just talked about, patient compliance and the quality of the data, cleaning the data. That's business as usual, really, isn't it, with big data? This thing about biasing the results, this came up. One of the questions that came for our pilot was during the pandemic, because we saw the number of registrations go up quite dramatically during the pandemic. Maybe the symptom scores reduced because there were more registrations from people who had less severe problems with COPD.
Okay.
And of course, that would bias the results.
Yeah, that makes sense. Yeah.
Yeah, I mean, I get the point here that the ethnicity might be a factor. We're not at that stage yet, although we do know from the literature that these different demographic information.
Yeah, exactly.
Yeah.
But that was our intention, but we did not have sufficient data.
Yeah.
Yeah.
The demographic information, yes, I can see is very useful. Although there are issues around that, because you then get the risk of re-identification increases. So we fall over privacy again. But, as we both found, that privacy is not necessarily an issue as far as the patients are concerned.
Not at all, yes. Not at all, yeah.
Yeah.
I mean, people are very used now, very familiar with this type of apps. Basically, all of them have the same requirements, and that was not present a major issue. Yeah,
and I was interested that so you'd done this study and everybody was actually very positive about it. I mean, as I said, our study with the myCOPD users, the clinicians were far less positive than the patients. But it's interesting as well that using apps gives the patients a feeling that maybe they're actually doing something to manage their own condition, which of course is very positive, because then they feel engaged and they can do something about it as opposed to having no control. That's interesting.
Yeah, so you also found the same results in general. There are no issues at all regarding data privacy.
That's true. Yeah, I suspect that a lot of that is to do with the fact that they, certainly in the UK, the patients trust their clinicians.
Yeah.
And then a secondary sort of consideration is that they want to do what is beneficial for the community. So, I mean, we've done studies elsewhere with rheumatoid arthritis, for example, and we explicitly said to participants, are you afraid that your data will be misused and sold to an insurance company? And they said, we don't actually care about the privacy of the data so long as it does benefit other people with this condition. So I think what we're both finding is that, that people are a lot more sophisticated about their data protection than we kind of think. And especially in a medical environment, with these apps, with these technologies, there's less concern that we think.
Yeah, exactly. Yeah, that was a very interesting finding. Yeah.
Yes. Yeah. I mean, I was quite surprised as well because if you look at the GDPR, I mean, like one of the ideas about the GDPR was to give the data subject, in this case the patient, more control over what they do and what happens with their data, which assumes, and again, there's a lot of empirical evidence here, that patients don't actually understand the implications, or the data subjects don't understand the implications. But for us in these pilots, we're finding that people are sort of saying, actually, as long as it's beneficial, either to me or other people who suffer from this, then we don't mind.
Yeah, exactly. Same conclusion as well. And also very practical. I mean, people do not need to go to the hospital on a regular basis like before.
Yeah.
And the number of visits to the hospital has been reduced, I mean, dramatically compared to previous process. And yeah, exactly. People seem to be more happy to use the app rather than any other security concern.
Yeah, indeed. And I think as well, you know, that there was the sort of economic side of it was the last presentation this morning where they were talking about asset control, and they could save money and all this, that, and the other, which of course is very, very important in healthcare. But there is a different side of it, in that really it's all about a more efficient use of resources. So you know, in our case for COPD, people didn't want to go to hospital. If they could help it, because of course they were vulnerable during the pandemic.
Yeah, and even more with the pandemic. Yeah.
Yeah, but I mean, I could imagine as well during pregnancy.
Yeah, as well.
Yeah,
a key concern to go to the hospital.
Yeah. So in fact, a lot of what we're seeing in these pilots, for the self-monitoring pilots anyway, is really providing autonomy for patients, which is quite nice. You know, so they start to be able to make decisions for themselves. Their care is more to do with when it's really needed, as opposed to just you know, monitoring what's going on. So I think these are nice. Apart from the fact that we're seeing similar things in different pilots, they're also interesting outcomes, I think.
Yes, indeed. And also regarding this easy to use, I mean, in order to get access to the disease, people are also very happy because we have introduced a video. It's very easy to follow, to explain the disease, how it works, what is best, and a sort of guidance. Also, these frequent asked questions, which solves a lot of doubts with the patients. And they can also communicate with their clinicians at any time, very easily from anywhere in case of doubts. So yeah, it was well received as your app as well in general.
Yeah. Okay, I think we're coming towards the end, because we have another parallel. I have another parallel session to go to in a minute. So what would be your take-home message from GDM?
From GDM, that what we initially thought at the beginning of the study 3 years ago or 3.5 years ago, that maybe was problematic for the clinicians to adopt this new technology. In the end, after interacting and continuous communication with them and explaining how everything works and there are no security concerns in general, it was easier as expected.
Yes. You took the words out of my mouth. I would agree entirely. You know, what we saw several years ago, we've done this, we've done that, but in fact it's a lot simpler.
Yeah. And also they have learned how to input the data. Before, I mean, everything was maybe on paper or here and there spread, but now everything is more structured.
Yeah.
And it's getting better and better. So the more that they get familiar with the technology, the better that it is and more accepted. So
Yep.
I think that was a huge step moving forward to the adoption of big data technologies. And furthermore, they were very happy, so they would like to continue the pilot
Yeah.
beyond the project. And our intention is to continue recruiting patients and yes, continue the pilot more months after the project.
Yes, and I mean, again, that's what we're doing. You know, we've got some follow-on funding, but I think the important thing one of the important things with BigMedilytics is, as we've seen today, you know, there is commonality across different pilots, but also it's given an opportunity to explore what the real issues are.
Yeah.
So that we can go forward.
Yeah. A lot of lessons learned from this.
Yes.
Project.
Yeah.
Complex, but very interesting.
Yeah, indeed, complex but very interesting. I think that's a good place to stop.
Yeah.
Okay. Thanks.
Okay. Thanks a lot, Brian and Klemens. Sorry that you had these technical issues. If you can hear us.
Yes, Paul Klemens.
Yeah.
But yes, and I hope anybody else listening in on this session got something out of it. What's your booth number? Marga?
Booth number is I need to check.
Okay. Yeah, people will get people will know how to contact you.
I think they are classified according to the disease.
Yeah.
It's easy to find.
And so any issues from anybody who's been listening in, please send them over to us and we'd be more than happy to answer.
Yeah, sure.
Okay.
Okay.
Thank you, everybody.
Thanks, everyone, for participating.
And enjoy the rest of the day.
You too.
Thanks. Bye-bye.
Okay. Bye-bye.